So tell me, we will start with few questions. Who coined the term schizophrenia? You can tell anything. Yeah, Sigmund Freud. Then, so normally you will get these type of questions only in NEET PG and AIMS, INI. So the one who gets the correct answer will get a chocolate. At least in between four of you. So the term schizophrenia was coined by Sigmund Freud. So no one, you can say anything. You don't know. So the term schizophrenia was coined by Eugene Bleuler. Tell me how these are related. Do you know any one of this person? Have you ever seen? At least did you watch that film, A Beautiful Mind? No. So you can go back to your rooms and you can watch that film. Okay. So this is John Nash. Okay, this is John Nash. He got the Nobel Prize in 1994 in mathematics regarding game theory, and he was the one, he suffered from schizophrenia. So we can say that the person who is having schizophrenia is completely not equivalent to intellectual disability. So the persons who are having schizophrenia can have their own independent intellectual abilities. Okay. So if we see the basic history, it started with Cherka. They described patient as gluttonous, filthy, walks naked, has lost his memory, moves about in an uneasy manner. So these are the writings that we can get from mythology. Then followed by Benedict Morel, he coined the term dementia precoce, followed by Emil Kraepelin, dementia precox. Why they have coined the term dementia precox is, dementia is forgetfulness. Precox is at an early age. So the forgetfulness which occurs at an early age, so they thought this could be the schizophrenia. Then followed by Eugene Bleuler in 1911, he coined the term schizophrenia. Also Eugene Bleuler gave 4 A's of schizophrenia. They are autism, ambivalence, loosening of association, and affective flattening. So autism is living in his own world. Ambivalence is not able to decide to or against. Loosening of association is one of the thought disorder where the patient is not able to speak, or patient is not able to control his thoughts. And affective flattening, the term it suggests there is a flattening of affect. Then followed by Kurt Schneider, he gave the 11 first rank symptoms of schizophrenia. Initially they thought these first rank symptoms of schizophrenia as the cardinal primary symptoms of schizophrenia. So if a person is having these first rank symptoms, then we can say that the patient is having or suffered from schizophrenia. So these are the first rank symptoms. 3 perception, 3 thought, 3 made phenomenon, and 2 special. So perception, it includes first person, second person, and third person. First person is hearing my own thoughts, that is audible thoughts. The second person would be one person is talking about me. There is only one person who is talking about me, and the third person is voices commenting about me. There are 2 to 3 voices who are commenting on me. Like whatever actions I am doing, whatever daily routines I am doing, they are commenting on me. These are perception. Then coming to thought, there are 3 thought phenomena: thought insertion, thought withdrawal, and thought broadcast. Thought insertion is, for example, today many of you didn't attend the class. So one of you will get a thought that not attending the psychiatry class, it is not my own thought, someone has inserted in this thought in me. There is some alien or external force, he or she has inserted this thought in me, this is not my thought. That is thought insertion. Then thought withdrawal, something actively removing my thoughts. So other people are able to know, but they are actively removing my thoughts. Then thought broadcast, they are freely going. There is no external agency, but thought broadcast, they are freely going. Whatever I am thinking, everyone is thinking in the same way. Then there are 3 made phenomenon: made feelings, made impulse, and made volition. Feelings, Feelings do not seem to be one, so these feelings are not mine. They are given by some external force. Made impulses the same way, like impulses or drives are not mine, given by some external force. Volition or acts are not mine, given by an external force. And delusional perception. It is a normal perception for which a illogical and private meaning is ascribed to it. So for example, I am coming here. So there is no one except you four. So this is a normal phenomenon. If someone studies MBBS, because I have seen this same class in my MBBS. So I would say if a patient of schizophrenia, he will think that there are multiple people who didn't attend the class. So maybe there is something behind going against me. Maybe all of them have bunked the class because they didn't like me, or because they are thinking bad against me, or because they are talking bad against me. That is called as delusional perception. So this is a normal perception, but I am giving an illogical meaning to that normal perception. Then somatic passivity. So whatever I am doing, these are not my actions. I am completely being done by an external agency. So basically, schizophrenia definition, if we see, the schizophrenia is a disorder of distorted thinking and perception, and also by inappropriate or blunted affect. As I have already mentioned, the intelligence will be normal. So clear consciousness and intellectual capacity are usually maintained, but of course, in the course of the disorder, you will see most of the times the intellectual capacity and cognitive abilities will be deteriorated. So if we see epidemiology, the lifetime prevalence of schizophrenia ranges from 0.3 to 0.7%, and it is almost male and females, it is almost equal. In male, it will be an early onset. If we see the onset of the disorder, in males, much early it will be going to appear, around 10 to 25 years of age. And in females, there is a bimodal distribution. The first peak will be in 25 to 35 years, and the second peak will be after 45 years of age. So in males, there is only one age group where the schizophrenia will be seen, but in females, there are two peaks where you can see the schizophrenia. Even if you see the onset, there are three types: childhood onset, early onset, and late onset. Childhood onset means less than 13 years, early onset means less than 18, and late onset is more than 45 years. Mainly I have focused very simple, and these are the questions that you will get in your NEET PG. So what are the types of schizophrenia? These are the most common types, but nowadays it is obsolete. No one is using these types of schizophrenia. In previous books they have mentioned. So paranoid schizophrenia, it is the most common type where the person having predominant persecuted delusions. Persecuted delusions in the sense someone is spying against me, or someone is thinking bad about me. That is called as paranoid delusions. And also prominent auditory hallucinations will be there, but personality is relatively preserved. There is no significant problem with the personality. Disorganized, also known as Hebephrenic schizophrenia, where you will be seeing disorganized speech, there is a significant problem with the speech, and behavior with a flat affect. So affect will be flat. Catatonic schizophrenia, this is a type of schizophrenia where you will see the predominant motor symptoms. There are several signs you are going to elicit in catatonia. For example, posturing, waxy flexibility, then cataplexy. These are the so in this catatonic schizophrenia, you will see prominent motor symptoms. Simple schizophrenia, predominant negative symptoms and social withdrawal. I will tell you what are the negative symptoms and other things. So what do you mean by von Gogh's schizophrenia and Pfropf's schizophrenia? Do you know what is von Gogh's schizophrenia? So von Gogh schizophrenia is self-mutilation in schizophrenia. So at times you used to see patients who used to cut their own fingers, who used to cut their own body parts. That is where it is called as von Gogh schizophrenia. Then Pfropf's schizophrenia is, if in a patient of schizophrenia, he is also associated with mental retardation, intellectual disability disorder. Then you have that term, that is Pfropf schizophrenia. Okay. So self-mutilation in schizophrenia is called as von Gogh schizophrenia, and mental retardation with schizophrenia is called as Pfropf schizophrenia. So these are the main symptoms if we see in schizophrenia: positive symptoms, negative symptoms, and disorganized symptoms. In positive symptoms, broadly if you see only delusions and hallucinations. Okay, delusions is a false, unshakable belief. Hallucinations are something you are hearing without the external stimuli. Negative symptoms include affective flattening, alosia, anhedonia, amotivation, etc. And disorganized symptoms include disorganized speech, thought disorder, disorganized behavior, poor attention. So these are the negative symptoms. If we see evolution, evolution is basically completely a lack of motivation. The patient always sleeps, the patient always being lazy, the patient doesn't want to go to any work, the patient doesn't want to initiate any activities. And when coming to anhedonia, it is an inability to experience pleasure from social situations or activities like eating, touching. So initially the patient is used to have these activities very pleasurable, but nowadays the patient doesn't seem these activities to be pleasurable. That is what called as anhedonia. Then social withdrawal, lack of interest in being with other people. Apathy, apathy is lack of feeling, emotion or interest. Affective flattening, as I have already mentioned, this is a flat affect. There is no emotional expressions in the face. Alosia, the patient is having significant difficulty in speaking. He will, there is significant decrease in vocabulary, so the patient doesn't want to interact. So tell me, what is the most common heritable psychiatric disorder? If you, so that means if the parents are having psychiatric disorders, highly chances that the children will be having that same problem, right? So what is that most heritable psychiatric disorder? B, schizophrenia, because the topic is schizophrenia. So the right answer is A, autism. It is having 90% heritability. Okay. Then schizophrenia and bipolar together constitute 75% each. So schizophrenia 75% and bipolar also 75%. So if we see what is the etiopathogenesis, why the person develops schizophrenia, there are several models that have been given. In that, one model will be vulnerability model, where the individual's premorbid personality, individual social network or environment, these three together plays a significant role in development of schizophrenia in a patient. So it will make the patient vulnerable, it will make a person vulnerable so that he will develop schizophrenia in later. Then neurodevelopmental model, during the birth or when in the mother's womb, there are significant complications when mother faces or significant complications when the fetus faces, that leads to schizophrenia, that can lead to schizophrenia. So obstetric complications, neonatal hypoxia are few of the examples. Then genetic model, as I have already mentioned, this is having 75% heritability risk. So there is a strong genetic link also that is associated with schizophrenia. So if one parent is having schizophrenia, the chances of getting schizophrenia is 12% for the children. If both parents schizophrenic, then 40%. Monozygotic, again it is 12%, and dizygotic it is 47%. So a patient with schizophrenia has prominent flat affect, alosia, evolution. Which neurotransmitter pathway is most commonly implicated or mostly implicated? So these are basically positive or negative symptoms. Flat affect, evolution, negative symptoms, very good. So which of these pathway is implicated in schizophrenia? So which of the pathway leads to these negative symptoms? See. So I am trying my best to give you chocolate, but still you are not. Okay. So the correct answer is mesocortical. Okay. So these are the pathways, 4 dopamine pathways. See. So the first, there are 4 pathways that are implicated in schizophrenia. That is mesolimbic, mesocortical, nigrostriatal, and tuberohypophyseal. Okay. So mesolimbic. In mesolimbic, what happens is, if there is increased dopamine, that causes positive symptoms. Mesolimbic is basically from ventral tegmental area of the midbrain to nucleus accumbens. So the blue color one. So this one, this pathway is called as mesolimbic pathway, from ventral tegmental area of the midbrain to nucleus accumbens. So if there is increase of dopamine in this tract, that causes positive symptoms. Positive symptoms mainly include delusions and hallucinations. Then in this green color pathway, that is mesocortical pathway, again from the ventral tegmental area of the midbrain to prefrontal cortex. So if there is decrease of dopamine in this pathway, that causes negative symptoms. So increase of dopamine in mesolimbic pathway causes positive symptoms. Decrease of dopamine in mesocortical pathway leads to negative symptoms. Then this nigrostriatal pathway, as you have answered, so it leads to the side effects of the antipsychotic drugs. Okay, so if we give an antipsychotic drug, it leads to EPS. EPS include dystonia, akathisia, pseudoparkinsonism. So this nigrostriatal pathway leads to the side effects of this thing. Okay, then the last one, that is tuberohypophyseal. So there decreased dopamine leads to hypoprolactinemia. Here tuberohypophyseal means hypothalamus to median eminence. Okay, so in tuberohypophyseal it leads to hyperprolactinemia. Okay, so this nigrostriatal and tuberohypophyseal are mainly related to the side effects of the drugs, but mainly mesolimbic and mesocortical pathways are mainly related to the schizophrenia. So how do you diagnose schizophrenia? There are two books that we prefer, that is ICD-10 and DSM-5. Here I have mentioned only DSM-4. So currently there is new thing that came up is ICD-11 also. Okay, 11th version. So in ICD-10, at least one of these things should be present. Like one of these symptom if present, then you can label that patient as schizophrenia. According to DSM-5, 2 are of these 5 symptoms. Normally this question will be asked in NEET PG. What are the 5 symptoms in DSM-5? That is delusions, hallucinations, disorganized speech, disorganized behavior and negative symptoms. If 2 out of 5 are present, then you can label the patient as having schizophrenia. But how many days? What is the duration of these symptoms? That comes here. In ICD-10, it has mentioned if the symptoms present for more than 1 month, then the patient is schizophrenia. If the symptoms are more than 6 months, so the patient should have these symptoms for more than 6 months, then you can label the patient is having schizophrenia according to DSM-5. Okay, so according to ICD-10, 1 month, and according to DSM-5, it is more than 6 months. So what are the differential diagnoses? So the first differential diagnosis that comes into mind if a patient is having schizophrenia, or the patient presents with the symptoms resembling to schizophrenia, are substance induced. For example, cannabis induced psychosis and this amphetamine. So this amphetamine, cocaine, cannabis, stimulants, PCP, anticholinergics and LSD. Also there are some other primary psychotic disorders which resemble to the symptoms of schizophrenia, includes brief psychotic disorder, schizophreniform disorder, BPAD, manic type, mood disorder with psychotic symptoms. So in case of mood disorder, BPAD, the same symptoms the patient would resemble. Also there are certain personality disorders. As I have already mentioned, there is a vulnerability model where the patient predisposed to these predisposing factors like an personality, the person can develop schizophrenia. These are the personality disorders: schizotypal, schizoid and paranoid. So which of the following symptoms best predicts poor functional outcome in schizophrenia? So out of these 4, which symptom if the patient is having, then you can say that the patient is having a poor prognosis. Negative symptoms, very good. So you got it finally. So these are the prognostic factors. There are some good prognostic factors and bad prognostic factors. Okay. So if there is late onset of schizophrenia, that is a good prognostic factor, but early onset, that is a bad prognostic factor. I have already mentioned childhood onset is less than 13 years, early onset is less than 18 years and late onset is more than 45 years. So females are having good prognosis, males are having bad prognosis. Marriage is a good prognosis and bad prognosis, because marriage itself creates an hope, marriage itself creates a responsibility. So that makes the person to live more life when compared to the person who haven't married. Okay. So onset, if it is an acute onset, always acute problems, they are having good prognosis when compared to the subacute and slow and insidious. So if there is a precipitating factor, for example, if the psychotic symptoms are precipitated by a stressor, there is a function in the home, or there was some substance induced, then that indicates a good prognosis when compared to the person who are not having a precipitating factor. Symptoms, again the positive symptoms are having good prognosis, negative symptoms are having poor prognosis. Subtypes, this is very important. Paranoid and catatonic schizophrenia are having good prognosis, Hebephrenia and simple schizophrenia are having bad prognosis. So how do you manage? So management of schizophrenia is not limited only to the pharmacotherapy. When the patient comes, you just give the medications and you just send off the patient. That is not how it works. So management includes both psychotherapy and pharmacotherapy. Okay. So what are the goals and management of our treatment? So you have to initially minimize the symptoms of schizophrenia. Also, you have to improve the quality of life and socio-occupational functioning of the patient. Once the patient is doing well, you have to prevent the relapses. Relapse means again the re-emergence of the symptoms that you have to prevent. And minimize adverse effect of the medications. If you start the medications, then at the same time you have to think that there should be minimal side effects of the medications. So when do you decide whether you go for outpatient department or inpatient department? So inpatient department, if there is a presence of suicidal behavior, the patient presents with suicidal behavior, again you need to admit. If the patient is associated with severe agitation or violence, which is uncontrollable through verbal de-escalation, then you can admit the patient. Refusal to eat, the patient is not eating for the last few weeks or few months, then again you have to admit, which is associated with severe malnutrition, unable to take care of self. Catatonia I have already mentioned, this is mainly associated with motor symptoms. So if the patient presents with catatonia, ECT inpatient admission is one of the good approach. And comorbidities, if the patient is also having other comorbidities, physical complications, substance induced, and there are other disorders you want to rule out, then also you can admit the patient. So pharmacological management, how do you decide? So there are two antipsychotics, first generation and second generation. So APA, American Psychiatric Association guidelines, they recommend the second generation antipsychotics to be used for the first. Okay, because there will be less EPS. Only the reason is there is less EPS. Even you can start pharmacology based on patient preference also. I will give the patient a basket of medications. See, you are having schizophrenia. So the patient's preference and previous response. So these are the antipsychotic drugs, that is first generation and second generation. So you can go through them, like what are the medications that comes under first generation and second generation. So what are the side effects of antipsychotics? They come under a broad side heading of extrapyramidal side effects. So that is mainly due to decrease of dopamine in nigrostriatal pathway. So acute dystonia, it is a sudden muscle spasm which almost the patient resembles in emergency department, mainly occur in the eye, neck, face and throat muscles. Management includes anticholinergics like trihexyphenidyl, benztropine and diphenhydramine. Akathisia, the patient presents with inner restlessness. The patient can't sit for a long time at one place. So the management include reduce the dose of the medications. If you want, you can change the antipsychotic also, and you can start propranolol. Then pseudo-Parkinsonism, the patient presents with the Parkinson's features, but these are due to antipsychotic induced, that is why it is called pseudo-Parkinsonism. So a patient presents with tremors, shuffling gait, mask-like face, cogwheel rigidity, and management includes again anticholinergics. Tardive dyskinesia, these are the movement disorders which include tongue chewing, lip smacking. Again, the management would be vitamin E and tetrabenazine. So how most of the times the patient comes to you, being you after MBBS, you will start yourself as a medical officer. So most of the times patient will come to you, see doctor sir, I have been diagnosed with schizophrenia. Since last 1 year I have been taking medications. So when can I stop the medications? So this is a very common question that you would encounter. So you should be in a position to be able to answer. So you have to say, if it is a first episode, then the patient has to continue at least for 1 to 2 years. Then if there are multiple episodes more than or equal to 5 years, there are certain signs and symptoms. If they are present, for example, suicidality, aggression, violence, then you can say that the patient has to take the medications for lifelong. Okay. So non-pharmacological management, it doesn't restrict only to the pharmacology. So you have to start with non-pharmacological management because the patient is having symptoms for few years, last 1 to 2 years. The family members thinks that they will be controlled by themselves, but still they didn't control. The patient didn't go to work. The patient stops eating, he will be having a poor self-hygiene. So you have to start non-pharmacological management during the inpatient stay only. That includes social skills training. So if the patient know few of the techniques, then you have to tell him like how to interact with the patient, interact with other social persons, how to interact with other patients, how to interact with the doctors. These things you can train. Family oriented therapy, which includes we have to psychoeducate the family members. These are the problems, this is the disorder, these are the things that happen. Then you have to control expressed emotions. Being the parents of a schizophrenic patient is not easy to manage. So they are the ones who will burn out first. So you have to tackle those expressed emotions. Individual therapy help in interpersonal relationship. For example, if the patient is married, if the patient is having children, so how to establish or how to maintain those interpersonal relationships, you have to tell them. Group psychotherapy, so you can start a group therapy where you can suggest or advise each patient what are the things that they know, they can share their own things. And at last, rehabilitation includes so not only controlling the symptoms of schizophrenia, you have to rehabilitate the patient. So the patient has to go back, to his normal occupational and social function. That is what our main motive is.